He completed a certificate in advanced graduate studies in prosthodontics and a master degree in restorative sciences in prosthodontics from Boston University School of Dentistry in 1999. Dr. Baba serves as a professor in advanced education program in implant dentistry at Loma Linda University School of Dentistry and maintains a part-time private practice in Glendale, California. He is a past president of the American College of Prosthodontists, an active member of various professional organizations, a diplomat of the American Board of Prosthodontics, and a fellow of the American College of Prosthodontists and the Academy of Prosthodontics. He is the author of numerous publications and has lectured nationally and internationally. Welcome, Dr. Baba.
Good morning. Thank you for your kind introduction. First of all, I would like to thank all of you for being here. I thank the Kuwait Dental Association for inviting me and giving me the opportunity to share with you some thoughts this morning. It's such a great pleasure to be here and such a great pleasure to see some of my previous residents and my colleagues. And I'm very honored to be around you today. So if you take a picture of your QR code, you can get a copy of the presentation. And I will have it also at the end of the lecture for you to take a photo of that too. My clicker is not working. Today we have an increase of aging population. We have a rapidly increasing patient base. We have an increasing complexity of patient care and an explosion of modern dental technology. And all of this have pushed us to stay up to date and to try to, as much as we can, keep our practices up to date and running. One thing we just want to look at is complete edentialism. And I wanted to look at the literature, and I found that complete edentialism varies excessively between regions and areas. And if you look at the population age between 65 and 74 years old with loss of natural teeth, that you can tell that each continent has a different percentage of edentulous people. But there's one thing that is sure, that there's more than 240 million people that are partially or completely edentulous. Edentulism is more widespread. Edentulism is going to remain a great challenge in the future. And edentulism also is a public, a growing public health concern. One second, I'm sorry. So if you look at the statistics, that between 1988 and 2002, there was a 6% reduction in complete edentulism. But there is a steady need for treatment due to people living longer. Economically affluent baby boomers account for 20% of the US population. They are the driving force or the driving future of market growth. There will be definitely a continued growth of edentulous patients, and there is an increased demand for complete dentures in the next 30 years. One thing for sure is that you will need to understand the basic principles of complete dentures in order for you to fabricate all these hybrids and all the prostheses that go on top of your implants. So different alternatives have been introduced through the years to enhance the stability and retention of dentures. One of them is this, I'm just a joke. The people are adapted to some vestibuloplasty. They also did these prong dentures to try to get some retention from under the nose. And also, they used some torture devices like these pins that were placed into the implants to create some inflammation of the soft tissue that will hold the dentures in place. It wasn't until implants were introduced, and they were not introduced recently, they have been used for so many years, But until the introduction of implants, that treatment alternatives have changed. So for implant prosthesis, what you can do is different treatment modalities, whether you want to go with mucosa and implant-supported prosthesis, or whether you want to go with an implant-supported prosthesis. For complete edentulosum, you can either go with a complete overdenture, but you can also go with an implant-fixed complete denture, which we commonly call hybrids. So not too many Americans underwent full arch procedures. So there is definitely a lot of room for implant-fixed complete denture treatments. Only 14 CODA-accredited dental laboratory programs exist in the United States. Because of this profession's behind the scenes work, recruiting students is very difficult. Shortage of qualified dental technicians is an issue. That's why we moved into the digital worlds to fabricate our prosthesis, because there's a lot of advantages of going digital. Shorter production time, superior fit, less lab steps, superior strength, repository of digital data, superior quality of the work you're doing, reduced number of interfaces, and reduced treatment length, among other advantages. So digitally, the prosthetic planning workflow could be done in different ways. Either you can make a conventional impression, pull your cast, do a verification jig, and then from there, you send your work to the lab, they digitize your work, and they fabricate for you the prosthesis. But you can also go all the way digital. You can get a CBCT, you can scan your patient or the impression of your patient, and from there get into a diagnostic software that will design for you the temporary prosthesis, the definitive prosthesis, and take you all the way to the end. So when you're restoring full arch prosthesis, would you go with fixed or removable full mouth reconstructions? The answer is really both, because it depends on the patient needs and preferences. It depends on the anatomy of the bone, whether in the maxilla or in the mandible, and it also depends on the financial commitment of the patient. Don't forget, these procedures cost money. Between the implant placement or some adjunctive therapies and the definitive prosthesis, there's a lot of money involved. So the patient needs to be ready to go into such a treatment. I started recently learning how to fly, and I realized that there is only one way to land my airplane. But in dentistry, there is no one way of treating one patient. There's multiple ways. Everybody can treat the same patient different ways. So again, but there should be some guidelines when you try to restore fully edentulous patients. There's some functional factors that you have to look at, but there's also some aesthetic factors that you have also to evaluate. So, but how do you determine the restorative space when you look at patients like these? It's even more difficult when a patient has already been restored and their cases are failing. That you have to start somewhere, isn't it? So it could drive you crazy, because it is very difficult to start when there is a lot of mess. It's easier to start when nobody has ever touched the patient and you're going to diagnose and treatment plan and execute your work. It's much more predictable and much simpler. Now, vertical space requirements vary between different treatment modalities. So if you're looking for an overdenture, the treatment space, the vertical space requirements is different than if you're going to restore with a fixed complete denture or a hybrid. And also depends on the material you're going to be choosing to restore that arch. The important thing is that gather the information, gather data as much as you can. The first one is basically the history and chief complaint. Understand the patient expectations and discuss the finances. You notice this is the first thing that we discuss, because you don't want to spend your time and waste your time and patient says, I can't afford it. So that's why it's important to discuss this first. The art of conversation lies in listening, that you have to listen to the patients. What is it that they want, and how much are they willing to invest time and money into that treatment plan? The second thing in the diagnosis is look at the aesthetics. One thing I learned is that ask the patients and evaluate their mouth and ask what is it that they're looking for. There is a checklist that you have to go through, and it's a checklist that you do during diagnostic and planning phase. There are 7 risk factors that you have to look at in order to find out, is my case easy, is my case moderate, or my case difficult? So again, the level of risk needs to be assessed. One thing to assess what you're going to be doing is getting a proper evaluation and using a diagnostic prosthesis, a wax-up, or a digital tooth arrangement. But you have to know where you're going. So it's like when you're building a house. You need an architect to draw and show you how your house is going to look like, and you need somebody to assess the land, make sure that the foundation are solid to withhold all this house that goes on top. Same thing in dentistry. That you have to do is find out where you're going, and according to this wax-up or diagnostic prosthesis or the digital tooth arrangement, figure out, can I give him a fixed or should I go with a removable? One thing I learned is ask the patient to give you photos that when they were younger. And that teaches you a lot about where you're heading or what is it that the patient is going to look like. I always ask for photos at different stages of their life. One thing I learned that aesthetic requires the knowledge of facial aesthetic coupled with knowledge of natural tooth position. What I use now is this Ivocolor Smile app. So you can download it, and what the app does, you can use either your iPhone or an iPad, take a photo of the patient, and that's me, and then what you do is you start editing. And then what you do at this stage is basically pick up the shape of the teeth that you want, and then what you do is you pick up whether you want to go with the basic or an advanced step, and there what you do is you look at the natural teeth, because if a patient is edentulous, you can also use that app, and it gives you a virtual setup that the patient can see how they're going to look like. But also you can use that with natural teeth. So what you do then is you pick up the size of the approximate teeth that you're looking for, and then what you can do is edit both the vertical shift, the horizontal shift. You shift the teeth back and forth. You can rotate the teeth laterally or vertically. And then once you have all of this, then you can evaluate the before and the after, and you can also send that image both to the patient and to your lab technician. This is a very powerful tool for diagnostic. I love this because it can show the patient right away what to expect. Anyway, the key values of using something like this, an augmented reality software, is that you have a real-time visualization of aesthetic options directly in the patient's mouth. You have an adjustment and final visualization that can be shown and discussed with the patient within minutes. So if a patient says, oh, the teeth look too long, what you do is you can shorten them, or if he feels that, oh, the teeth are too large, you can change the mold. So everything can be done chairside. It's a powerful and fast visualization compared to time-consuming photo shooting and mock-ups. You see, I always tell the students that if you want to go buy a pair of shoes, you need to see it, isn't it? You try it, you look at it, you pick the color. But if you don't know what you're buying, you're not going to buy it. It's the same thing for the patient. You're talking to them that you want them to pay $40,000 to get a prosthesis. They don't even know how it's going to look like. It's a little bit tricky. When they see it, they see how it might look like. It might give them a little bit of energy and a little bit of encouragement. In the incisal, in the diagnostic, you're going to look at the incisal edge position. This is an extremely powerful tool. What we use is we use a papillometer that we have it rested on the ridge crest, both the upper or the lower arch. And then what you do is you measure the distance from the incisal papilla to the lower edge of your lip. What does that give you? It gives you the length of the maxillary lip, the position of the incisal edge of the future teeth, and the length of the teeth that you're gonna have to pick. I also do that, and I take photos of repose and smile. Why I do that? Because I want to determine if the prosthesis mucosal junction will be visible. I mean, if you look at that patient, she got all the job done, she paid a lot of money, but she didn't expect to get a result like this. Why? Because the doctor who treated her didn't take the time to assess the lip position or the length of the lip and make sure that when the patient smiles, the bone doesn't show. So anterior aesthetic is also going to determine the tooth display, and it will help determine the occlusal plane location. Race, gender, lip thickness, and age play a role in this position of the anterior teeth. Now, let's look at the relationship of implant to ideal incisal edge. When you look at the patient like this, patient came to the office, said, I want to get new prosthesis. My old prosthesis broke. Well, if you look from the frontal view, I would say, boy, I have a lot of room. But basically, if you look from the lateral side, you notice that that patient's bone is too far lingual. Putting a fixed complete denture here, gonna put a lot of cantilever on the prosthesis. It's gonna cause the prosthesis to break, the implants to break, or the bone to get lost. So it's unfavorable for a fixed treatment. This patient will be better with an implant over denture, with denture flanges that would be more favorable biomechanically, because you get maxillary lip support, you get facial contour that could be obtained, and reduced implant overload. It is important that you get a tooth setup, just with the denture teeth setup, just to get an idea of where the implants are and where the future teeth needs to be. It's excessively important. Why? Because you don't want to place the implant before you get the teeth set up. You have to provide your surgeon with a surgical guide. Because if they place the implant not knowing where the future teeth are going to be, you might get them in a less than an ideal position. One way to get that evaluated is if a patient wears an existing denture, you just have to duplicate it. And what I do is I cut the flanges, you notice, on the left side of the denture, and have the patient wear it. And when the patient wear it, have him smile. And then you can tell where the teeth are going to be, and then you can also tell if a patient smiles, if he's going to show aesthetically, if it's going to be pleasant and you're going to get enough lip support. The other thing is to evaluate the biting force. Recently, I started using this device. It's a Canadian company that came out with it. It's called InnoBite. What it does measure, it measures the biting force. So this device has liquid into that rubber component. The patient bites on it, and you can get the measurements of the force of the bite in Newton. Why is it important? Because look at that. This is my own bite. I have 1,496 newtons that I can apply. So I can crush anything, isn't it? But if you look, this is in the excessive side, which means I have to be recommended a night guard. So if a patient comes to you and you evaluate the biting force, then you can tell, okay, is he gonna be better with the zirconia or is he gonna be better with acrylic? If a biting force is too strong, you'd be better off going with the zirconia because he's gonna crush your acrylic easily. The provisionals are basically a blueprint. Whether the patient doesn't have anything, you have to start with a complete denture. But if they are wearing a hybrid and they want a hybrid, you can also get a temporary hybrid. What it helps you do is establish the incisal length. It helps you correct the midline position and cont. It helps you correct the incisal line angles, correct the incisal and posterior planes, and also gently test the incisal guidance. These are extremely important. And what you can do is you can either do them conventionally, they can get them mailed, or you can get them printed. It doesn't make a difference. But let me show you what I've been doing recently. I use the Ivoclar Ivotion system. These are the mailed dentures. So what I do is you can either acquire impressions in an analog way, or you can do them digitally. Then you do is you pick up your material, you design your dentures, or the lab designs them for you, and then what you do is you can have them milled for you. This is a one pack that has one side you have for the teeth, and the other side is for the interior surface of the dentures, the base. They are milled in 1 hour, and you get the dentures finished in just 1 hour. And then all what you get is you get the dentures milled to completion. They require very minimal polishing to get something that looks very nice and very decent. So this is how the dentures look. They need minimum adjustments. All what I have to do is individualize the teeth with the diamond disc, polish the acrylic, and they're ready to go. This patient is 93 years old, and I picked up some teeth that kind of reflect his age. Not too bright, and the teeth have a little bit of wear on the incisor. It looks very natural and very pleasant to the eyes. Recently, I've been trying the Ivotion-based print. This is a material from Ivoclar that you print the base, you mill the teeth, and you bond them together. This is for the people who want to have that printing option in their office. This is an amazing option. The good thing about this material, it is PMMA, it is relineable, it's repairable, contrary to all the printing materials that are available on the market. Once the dentures are designed, what you're going to do is have a trial, a prototype to try and evaluate the dentures that you're going to be finishing. You can do all the adjustment on this prototype, adjust the occlusion, evaluate the aesthetics, the phonetics, and so on and so forth. And then once this is done, all what you have to do is print the base. It's not a long procedure. You can only print up to 4 dentures on the printer, and then once they're done, you get them finished. You mill the teeth. The teeth are milled in one piece. The PMMA milled, very strong, and then all what you have to do is bond them to the base using an Ivotion CAD material. And then once you get them done, what you have to do is polish the dentures and deliver them to the patient. This is before and after. There's one thing, aesthetically, they look very pleasant because the teeth are milled. They can be milled in any shade, and they can be milled in what we call the multi, which means they have an incisal, translucent incisal edge. They look very pleasant to the eye, but one thing, according to our colleague Brian Goodacre, who published this manuscript on 3D printing of complete denture, a literature review, he found out that there was an improved aesthetics with the milled material. There is a denture-based adaptation that is as good as the milled ones. You have a material strength. The materials are getting better and better every day. But there is one thing, a lot of materials are not repairable. They have some color stability issue because they're composites and they change shade with time. They also stink because they're porous, and plaque and stain adheres to the material, and then they're very difficult to reline. So there is definitely need for more research with printed materials. So let's look at some biomechanical consideration when you want a treatment plan your patients for full arch restorations. The first thing you look at is the number of implants. The optimal number of implants must be chosen on the basis of patient's cost and perceived patient benefit, bone and soft tissue quality and quantity, the primary implant stability, and the anterior-posterior spread of the implants. So, over-treating patients is not a solution. I'm sure you make more money by placing many implants, but is it beneficial for the patient? No. Is it beneficial for you? No, because if this something fails, it costs you a lot more money to fix. There's little evidence to support the implant number as a factor of patient satisfaction. Evidence does show that simple rather than complex design that allow for ease and maintenance and cleaning are preferred by the patient. So 4 to 6 implants have been successfully used in both arches. Now, if you look at this systematic review, they used 4 to 6 implants and a very well-documented treatment option with high 5-year survival of superstructure. They found a substantial lack of evidence to determine optimal number and distribution of implants. Now, in the mandible, you need fewer implants than in the maxilla. Well, since the implant rate, success rate is higher in the mandible than in the maxilla, you definitely need less implants. And the other issue is the distance between the mental nerves, the intermental foramina is very small. So you don't have a lot of room to place a lot of implants. That's why 4 to 5 implants are usually recommended in the mandible. In the maxilla, the placement of 2 frontal axial implants and 2 distal tilted implants lead to a high survival rate. Placement of supplementary implants just to avoid revision surgery should a failure occur does not seem reasonable anymore. When I started my pros training, we used to place 10 implants and we will have only 6 or 5 that will stay, the remaining will fail. But today, the survival rate of implants is very high and there's no need to do such a thing anymore. Let's look at the length of the implant. There is no evidence available evaluating short implants in the full arch fixed restoration of maxillary edentulous patients. One cannot state yet that applying short implants for implant fixed complete denture is a safe and predictable technique for the edentulous maxilla rehabilitation. When you look at the anterior posterior spread and cantilever, establishing a well-distributed 4-point stability and minimizing the distal cantilever contributes to both implant and prosthesis success. In the mandible, the recommendation that cantilevers may extend at most 1.5 times the anterior posterior spread was empirically established and should be modified to the estimated applied forces and the number of implants. So in the mandible, if you have the chance to add some implants distally to reduce the use of cantilevers and to get a better stability, it is much better. Same thing in the maxilla, but in the maxilla, what you want is 1 time the anterior posterior spread. You don't want your cantilevers to be excessive in the maxilla. They should be much smaller than what you can get in the mandible. When you look at axial versus tilted implants, well, of course, placing the implants tilted is going to help you move the anterior posterior spread a little bit more distal. And that will improve your anterior posterior spread and give you a little bit more leeway to place a cantilever if you have to. And that's what I did in that particular case. You notice I added only 1.5 tooth distally. So the advantage of tilted implant concept is you get fewer implants and you have a reduced cantilever. And the longer implant enhances posterior support and minimizes or eliminates the need for grafting in many cases. So tilted implants, it's a very sensitive technique. It's useful for patients with resorbed ridges and there is a lot of need for long-term studies. It's excellent for patients that have pneumatized sinuses and resorbed ridges in most patients. If you have pneumatized sinuses and resorbed ridges, tilted implants are an option. The other option is also to use zygomatic implants. The good advantage of tilted implants is you can use them for immediate loading and use them with guided capacity. So what about materials? The materials, you can use a variety of materials when you restore full arch restoration. You can use acrylic, you can use zirconia, and you can use a combination of both. So I'm going to try to show you a little bit of everything. Now, prosthodontists are viewed as master diagnosticians and highly skilled clinicians. Conceptual understanding, logical development, and current wisdom are required in making clinical decisions when to treat and when not to treat a patient. You have to understand your limitations. Do we want or can we handle the case? And the reason why I'm saying that is I'm going to show you a couple cases that present to your office with failing prosthesis. And these cases are much more difficult than if you start them yourself from scratch. So this is Robert presented to the office with many implants. First of all, he doesn't know who placed them. He doesn't know what the brand name is. And he has all these failures. And he said, aesthetically, they don't look good. I said, okay. The first thing I do when I see fractures of ceramics is to evaluate the biting force. His biting force was excessively high. And then what you see now is I'm going to have to go with zirconia rather than acrylic. But before I start, let's evaluate the case. The first thing you do is look at the implant brand name. Well, if you don't know what the implants are, how can you restore the patient, isn't it? And sometimes it's very difficult to get that information. You call the previous office, they say, oh, we don't have the charts, or we don't have the information of the implants. So there's 561 implant companies, there's 3,875 brands and models, there's 10,610 interfaces, and then 37 countries that are making implants. It's crazy, isn't it? Now, in 2023, the FDA cleared 33 new implants. So how often have you encountered patients with implant brands that you don't recognize? Okay, everybody has that. So one way to do it is to use this software. It's on the website. It's called whatimplantisThat.com. So what you do is once you open it, you provide the information about the implant, and then you can hopefully get through the x-ray of the implant, kind of figure out what implants do you have. There are also some different registries that are available to help you. But consumers want, and it's their right to own their information, isn't it? So we have an app for our cars, we have an app for the pharmacy, we have an app for everything. Why can't we have an app for implants? So a colleague of mine opened this app called ID2. And then what you do, it's a HIPAA compliant app. And then what you do is you choose the option you want, and it costs $30 per patient. So what I do is I add this $30 to the treatment plan. Patient doesn't even know. And what you do is you enter the information about the implant, and then you can share it both with the patient and your treating doctor. And the patient has access to the information forever. There's no limit how much they can use it. The other thing is, are the components available? Okay, now I found what the implant is, but sometimes, boy, I don't know who's the company. Company went bankrupt. There's no more components. So there are some third parties that provide us with some components for our implants. They're abundantly available. Some of them might be costly, but it's the only option you have. The other option is to evaluate the perio and the endo condition of your case. In that particular patient, he was going to lose practically a lot of teeth and implants. So I ended up with having a less than ideal distribution of implants in the mandible and also in the maxilla. So I had to do something about it. So implant position is very important. Now, most of you inherit cases like these. Now, the most beautiful one is the last one on your right side. It's just the cast was sent to me with the prescription, please restore. It's like, I'm a prosthodontist, I'm supposed to be taking a lot of junk, but it doesn't mean I can do miracles, isn't it? So implant position is extremely important, and the angulation. Now we have the possibility of using angled screw channels that makes it easier for the lab technician to provide us with something decent. In the old days, we had to go with all these multi-unit abutments, the cast abutments, and that was very costly and difficult to get you something that is decent. And today, with digital technology, makes it even easier because the implants are planned and placed in a very ideal position, and the restorations are designed at the same time. One other factor to look at is the restorative space, and we already talked about that. So for that patient, I removed everything, and I provided him with a complete denture. This is my blueprint. The lab is going to use these to, first of all, the oral surgeon is going to use this to place my implants, and then the lab is going to use this to fabricate my definitive prosthesis. I always go with the prototype. This is a milled prototype. Why I want that? Because if you look at the mandibular area, you notice that he has excessive bone. And that bone would have been an issue in the design of my prosthesis. So I had that removed by the oral surgeon and cleaned before me moving to the definitive prosthesis. One difficult thing to look at is if you remove an old prosthesis, can you put it back on? So you have to have a plan B, because for that particular patient, he already lost 2 implants, and he told me that on his left side, he has some pain. What I did is by removing the prosthesis, I realized that was an implant that was failing. And if you look even closer, you can tell that there is a piece of fruit that is left in the socket. So probably whoever placed the implant didn't clean the socket very well. Again, for that patient, you definitely need a backup plan. One other thing is to look at the financial commitment. For me, this is the first thing that I look at. I don't want to waste my time for him to tell me, I don't have this much money. Give me a denture. So I start with that. Why is that important? Because you want to know how much are they willing to spend. What you want to do is explain to them that from complete denture to hybrid, the cost goes up. So I usually tell them very easy. I said the complete denture is $3, the overdenture is $5, the implant-supported overdenture is 10, and the hybrid is 15. So they get an idea that the hybrid is the most expensive. So if they don't have this much money, they're not gonna drive me into it and then just try to dream about it and when they can't afford it. The other thing is there is little evidence to support that implant number as a factor of patient satisfaction. All what they want is they want something easy to clean and easy to maintain. So many patients I know have the potential to pay for their prosthesis, but they want something to remove and clean. So that particular patient, I restored him with an IPS EMAX Zircat Prime, and it's an amazing zirconia. Aesthetically, it looks very pleasant. The important thing is not to adjust the occlusion at the delivery. You have to try to adjust everything at the prototype stage, so you don't have to touch or damage the zirconia after you trial seat the prosthesis. Aesthetically, they look very pleasant and very nice. This is another patient, his name is Rafiq, came in, a maxillary overdenture mandibular hybrid. This last abutment was broken and they couldn't even take it out. He's sick and tired. He said, I can't clean it. I want something easy for me to handle. The guy is 79 years old and he goes, I'm spending more time trying to clean than eating. So we discussed, and it was more beneficial for him, according to his demands, to go with the telescopic bar. Basically, it's a mill bar with retentive abutments, and then on top of these, there will be a housing on top of which the structure is going to come over, whether you make it out of zirconia or acrylic, it doesn't matter. So this is the bars at the trial stage, put the framework on top, take a centric relation record, and at this stage, I have to tell you that it's extremely important that your impressions are accurate. And what you do is you need a verification jig to make sure that your cast is accurate before you fabricate the framework. Framework must be fabricated from materials and protocols that allow passive and accurate fit between the framework and the implants. Framework must be designed to resist tensile and compressive forces associated with mastication and parafunctional habits. So, a misfit of a framework can cause stresses in the implant prosthesis and the surrounding bone. Passivity of your framework means a long-term osseointegration of the implant. So what you have to do is when you get the framework is do a one-screw test. Now the one-screw test is basically easy. You put all the screws in, you tighten them by hand, and you loosen 3 of them except for 1. And you grab an X-ray. If the framework lifts up from the implant, that means it was under tension, and you don't want that. You want the framework to be passive. The screws are just to hold the framework in place, not to seat the framework in place. So for that patient, the framework came back, and then this is the framework that goes on top of the bar. All what I had to do is design a monolithic acrylic superstructure that goes on top. We call it an overlay. This is the printed trial. I love these. Notice the lab technician painted it pink and everything, but it was too bulky. So what I do, this is the best phase for me to adjust the prosthesis to what it should look like. So I grinded all the acrylic, adjusted the occlusion, I checked phonetics, aesthetics, lip support, vertical dimension, everything. This is my prototype. Once I'm happy with that, then I'm gonna go ahead and mill the definitive overlay. So the reason why you want it monolithic is because you get an increased strength. There's no bonding of the teeth. Teeth don't debond, they don't stain, they don't break. And if they do break, it's very easy. You mill another one, another overlay, you take the old one out, put a new one in. If the teeth wear, which could happen with time, same thing. And it gives you an appropriate AP spread. This is the definitive prosthesis after I delivered. The occlusion has been already adjusted. I tested everything, so there was no need to test anything at that stage. You just deliver. Very easy for the patient. He can take it out, clean it, and put it back in. He feels like he's wearing a hybrid because it's super stable. It doesn't cover the palate. Very easy to maintain, very easy to clean. Now, how about occlusion? Is there evidence to support the concept of implant occlusion? The topic, it's a topic of controversy. Everybody says different things because there is a lack of evidence-based implant-specific concept of occlusion. The information for implant occlusion is derived from occlusal concept from non-implant supported prosthesis. There is a lot of discussion about occlusion that are based on personal experience rather than on scientific studies. Primarily based on expert opinion, in vitro study, and animal studies. All what I want you to understand is that there is insufficient evidence to establish firm clinical guidelines. What you want to know is use bilateral balance articulation when the opposing prosthesis is a complete denture. In a case like this, patient wearing a maxillary denture mandibular hybrid, what you do is use a bilateral balanced occlusion. And if you have a fixed hybrid, use group function or mutually protected occlusion when there are natural teeth in the opposing arch. Cantilevers should be less than 15 millimeters in the mandible and less than 10 to 12 millimeters in the maxilla. If you can go away without cantilevers, it's much better. Let's look at Joanne. Joanne came in wearing a mandibular overdenture, excessive wear of the locator abutments, and she goes, "Doctor, I'm sick and tired of removing this. Is there any way I can get something fixed?" Okay, we discussed the finances. Finances are very limited. So instead of going with the zirconia, decided to go with acrylic because it's cheaper. So look what I did. It's a very easy solution that is now available. The first thing you need is what? Is your blueprint. That's a teeth setup of the denture at the exact vertical that you want with the occlusion and everything that is evaluated ahead of time. Then everything is scanned and a milled bar is designed. Now with that bar, on top of it, there will be an overlay of an ivosian denture, which means that the base and the teeth are in one piece. There will be no debonding because it's going to be very small. So you don't want to bond teeth in that particular prosthesis because they're going to be debonded. So what you do here is you mill the overlay and you mill the bar and you bond them together. And after you bond them together, what you want to do is use a locator fixed to attach this prosthesis to the implants. But before that, I want to talk a little bit about the complication with overdentures that I'm seeing a lot, with hybrids that I'm seeing a lot. It's mucosal hyperplasia. How do you prevent that? It's basically by creating a convex shape where prosthesis touches the tissue. What people are doing is this. So how in the world can a patient clean that? There's no way in the world they can clean it. So what you have to do is, what I usually do is I take these prostheses and I cut off all the flanges and I make them convex to make it easy for the patient to clean and get a proxy brush underneath. So going back to the patient, all what I have to do now is take this housing, snap it on top of the locators, and then bond it to the framework. It does not come out. You're the only one that can take it out. It is very solid. The inserts, you see the green inserts are made of PEEK, so they're not flexible, they're very rigid. So when they snap on the locator, they're just there and they don't move. There's a special tool that you use to seat the framework in place. The good thing about it, if there is wear, I can remove the overlay, mill another one, and bond it. So it's very easy, very affordable for me. So by changing the patient's implant-supported overdenture to a hybrid, I improved her biting force. She was complaining of not being able to chew. My device showed me it's 423 Newton. There was a light deficit, but now when I gave her the hybrid, the biting force became 790 Newtons. It improved her biting force and her chewing capability. So let me show you this one. This patient came in, went through a divorce, went through drugs. He lost a lot of teeth. He was depressed, and he wanted to feel better after the divorce. So he said to me, "Doctor, just if you can fix my teeth, I'll be very happy." The first thing you do is an immediate denture. Take all the teeth out, get an immediate denture, and after that, duplicate the denture, send it to the neurosurgeon who placed the implants for me. And then what I did is I decided to use this fixed bar design. It could be even an overlap, or just you can have an overlay on top. So here I use these multi-base abutment EV. The beauty about these is the screw is inside of the multi-unit abutment. So there's no opening to the oral mouth except for the screw that holds the prosthesis on the multi-unit. So what you want to do here is order the framework, and you notice the lingual is full metal, and the remaining is just an overlay that I'm going to be bonding on top. The abutment comes with a holder. You just put the bottom part of the multi-unit abutment in the implant. You screw it, you torque it, then you flip the instrument reverse, and then you have the other part of the multi-unit that is attached and then torqued. And at this stage, all what you have is you have these little multi-unit abutment with no holes, there's no screws in there. So it's very clean and it's very easy to use. Then once the prosthesis is finalized, so you want to go ahead and just seat it in the patient's mouth. I want to show you, this is a very interesting case that I treated with a colleague of mine in our department, Dr. Al-Arda. This is a patient that was referred to me by the ortho department at Loma Linda. The patient has been in the pros department for nearly 6 years and nothing has been done. So for 6 years, she was doing orthodontics and there was no guidance whatsoever. So the patient was upset, the mom was upset, and they were gonna sue the school. So what happened is that she was referred to my office by the ortho department to try to help them find a solution. One thing I know just from evaluating the patient is look at the angulation of the maxillary anterior teeth. There is no way in the world I can give her any fixed crowns or anything. One thing, I start with the basics. What's the basics? How much space do I have? Okay, look how much space you have. Look where her natural teeth are and look where the denture teeth are. So this is how much room she lost. So how in the world am I going to restore that if I don't take these teeth out and place some implants? Aladdin did an amazing job placing for me 4 implants. The patient is very petite and it was very difficult to manage her on the chair. So, but anyway, we were successfully able to place the implant. After healing, all what I had to do is a definitive impression, and I do that also with the definitive impression, and I also attach the impression post to the tray, and I usually make a duplicate of the denture that she's wearing. So this way, I'll be able to mount my cast on an articulator without having to bring the patient back. This is the prototype that I'm gonna try in her mouth and make sure that she's comfortable with, and I'm gonna process it. And after processing, she's gonna wear it for a while. while the definitive prosthesis is being made. For her, she was young, she's 24 years old. We decided to go with something a little bit more permanent. The teeth are going to be made of zirconia, but the base is going to be made of composite. So that's why I made this framework. It's a fixed hybrid prosthesis with individual crowns. This is the beauty of that material, is that it's in one piece. Now you have to be careful when you get in something like this. You have to make sure your cast is accurate. That's why a verification jig is a big must. You can't cut and solder. You can't adjust it. If it doesn't fit, it doesn't fit. You have to make a new one. That's why it's important that your impression is perfect and the cast is verified. Now, once you get that, the next phase is just to try it in a patient's mouth and do a one-screw test, make sure that it fits passively in the mouth. After that, I had some teeth that are made of wax that are milled. So these are milled wax teeth that are placed in there to assess everything. Now, we noticed the teeth were too long. She didn't like them, so I had to adjust them. And finally, this is how we ended up with something that looks very decent for her. An adorable lady. She's a bubbly person. She's on social media. She has her own Instagram account. She sings. She's an artist. She's amazing. I mean, and she's a very sweet lady. So one other way to do it, I'm going to show you, is if you already have a patient wearing a temporary hybrid. So instead of you making a regular impression, what you can do is digitize that impression to the lab. So what you do here is what you want to do is you scan the conversion prosthesis, you scan the opposing arch, and then you scan the occlusion. And then after you do that, all what you do is the next phase is you are going to remove the prosthesis and you scan the edentulous arches. So now you have the provisional, you have the occlusion, and you have the arches, isn't it? So what's missing then is what? Is your cast. But in order to make a cast, what you can do is put these, you scan the interim prosthesis in hand with the Revex scan bodies. These are scan bodies that you screw to the prosthesis. You scan it, and it gives the software the position of your implants. In order for this to be accurate, you have to start to scan the occlusal surface first, and then you scan the intaglio surface. So once you get that, so all what you have to do then is digitize that whole process. So from whatever you made, so you're going to get an intaglio of the soft tissues, the implant position, and the tooth position. And this is nice because you can let the patient still go home with the temporary hybrids. So he can still go home with it and test it. You don't have to keep it for the lab to scan it and to make the definitive prosthesis. And then he can test drive it and get the approval of the family. It will also help you evaluate the aesthetics, the vertical dimension of occlusion, and everything that the lab wants. And this is the definitive prosthesis. And basically, it sits on these BLX implants from Straumann. And again, it's very predictable, and it makes your life so easy, and it makes the patient's life so easy because you don't have to remove anything. You can keep his provisional in the mouth, and while you're fabricating the definitive prosthesis. And this is how the patient ended up. Now, implant survival rate, and I'm going to finish with this. Definitive restorations are beautiful when they delivered. And we assume that implants are at 85 to 98% success, isn't it? And most of us, and the patient for sure, they believe that implants are forever. Right? People tell me these are my permanent teeth. I said, there's nobody is permanent. There's only God is permanent. I said, I'm not sure you're going to have that for a long time. I said, nobody knows how much it's going to last. But if you look at the literature is clear. The older the prosthesis, the more complications you have, and the less is your survival rate. But that's for sure. So one thing to understand is if you look at the number of complications, number one is implant overdentures followed by implant fixed complete dentures. But if you also look at the incidence of percentages of failure, you notice that implant overdenture has a lot of failures, and an implant fixed complete denture is second. The negative outcomes are affected by an accrual of clinical factors. And one of the clinical factors is the biologic response, the health risk, and the quality of oral, quality of life. Now, the other factor is restorative complications, and we all have some. You have to be expecting that the patient are going to come back with failures. Could be failures of the structures, failures of the substructures, failures of the screws, failures of the implant. So and you have to be able to deal with these and know how to handle them. And the last factor is iatrogenic factors. These are caused by substandard care. Not everybody follows the rules, not everybody does ethical work, unfortunately. So patients end up, each one of these patients have a different story. The second one on the right had these for 6 months. So she came in with only 2 teeth left in the maxilla. She paid $40,000. She took a loan from the bank. And when she looked at me and she said, "Doc, I'm already in debt. Just give me whatever you have." I gave her an overdenture, implant-supported overdentures. But anyway, this is the only thing she can afford for now. So again, all these patients have misery and then have issues, and not everybody is happy to deal with that kind of things. Whoever thinks that a professional is expensive has no idea what an incompetent can cost him. And I always tell the patient that. I said, you want an incompetent person to give you the treatment because you thought I was expensive. So the funny part is they come to me, they leave, and they say, "Oh, it's too much for me, I can't afford it." And they come back, they want to fix it. It costs them even more money than initially what they were quoted. Patient main determinant of success is recall and maintenance. They are never told that they have to come back for maintenance and recall. A lot of my patients get overdentures on locators. They were never told that the inserts needs to be changed. I always tell them, "Don't you have a car?" They say, "Yes." "Do you change oil in the car?" They say, "Oh, yeah." I said, "You have to change the insert, same thing like a car. They need to be changed every 6 months. The dentures needs to be polished. It needs to be assessed. That you have to make sure, because the bone, the dentures are not going to change, but the bone underneath it is going to change. So you have to evaluate all of these things. It's very important to tell them. They are never told that they need to do these things. One thing I'm going to tell you, I know that printing is now a super hype thing, very nice, but you have to be careful. Now, these are 2 patients that presented to me in the last month. This patient is wearing a maxillary mandibular hybrids, printed. They are printed. He paid $46,000 for these. I mean, honestly, I understand printed as a temporary material, as a provisional hybrid, temporarily until you finish, but this is unethical. So look at the amount of plaque accumulation underneath. Look at the design of the prosthesis. When you make it convex, there's no way in the world they're going to be able to clean it. So, and then the other thing, this material is porous. It's a composite. Bacteria and plaque adheres to it very easy, very difficult to clean. Now, this is a second patient. Look at this one. The prostheses are fitting on the multi-unit abutments with no metal interface. So it's just the printed hybrid that goes directly on the multi-unit abutments. I mean, how in the world do you want this to last? I mean, again, this patient paid so much money, and he was angry. And if you look at the other aspect of it, if you want to be critical, so look at where the screws are. So look at the upper image. Look where the exit of the screws are. So that patient is not really a candidate for a hybrid, isn't it? And this is the mandibular. The maxillary is even worse. So I told the patient way before we started, I said, "Dude, you're going to have a removable denture." I said, "You won't be able to have something fixed." He said, "But they give it to me." I said, "But that's why it broke." So again, there's a lot of cantilever. So he applies a lot of forces in the anterior teeth. what ended up putting a lot of load on the posterior implant. And that's why it broke. Anyway, regardless of the cascade of events, multiple options of treatment must be considered before or when complications occur. Retrievability and maintenance are key. My advice to you, pick something that you know how to fix. If you don't know how to fix a hybrid, don't do it. If you know how to fix an overdenture, get it done. You have to learn how to fix it when it fails. Just because things do fail. We all have failures. But the beauty is to know if you can handle the failure and if you know how to fix it. If you don't know how to fix it, don't do it. Again, think outside of the box. Try different materials. I showed you different cases with different treatment modalities. There's no one size fits all. So I know it's a la mode to have a hybrid, but not every patient is a candidate for a hybrid. I know it's a la mode to have zirconia, but not everybody is a candidate for a zirconia. Assess your cases, evaluate your occlusion, evaluate your vertical dimension, evaluate the vertical space that you have. Discuss, talk, consult with others. There's nothing wrong with you showing the x-rays to a friend and asking his opinion. It's very important. Anyway, I want to thank you very much for your kind attention. This is a QR code that if you take a photo, you get a copy of my presentation. If you have any questions, you can send me a message on my Instagram. I'll be more than happy to respond to you. And again, thank you for the invitation. Thank you for being here. And it's an honor and a pleasure for me to have had the opportunities to share some of my ideas with you. And have a wonderful weekend.
Any questions?
Make them easy.
Thank you, Doctor, for the great lecture. I have two questions, actually. You show a case that we use. Can you hear me? Yeah.
It's not your fault. I'm hard of hearing.
I'm sorry.
And God gave me selective hearing, so when the wife nags, I hear only half of it. but I can read your lips.
Yeah. You show a case about you convert a locator's abutment to a fixed prosthesis.
Mm-hmm.
Why did you choose that approach?
Again, it's for financial reasons, and that's what I mentioned. See, the first thing I do is patient has 4 implants, very nicely positioned, bone is adequate, implant placement is good, I have a lot of room. So the next phase is to discuss money. So again, I said, well, what you can have is another overdenture. And she goes, no, I don't want that. I'm sick and tired. I don't want to keep taking it out. I can't chew. I don't feel my food. Okay, the next phase was you can have a bar with an overdenture. She goes, I still don't want that. I don't want to remove my dentures. The third step is to go with fixed. So then I evaluated the options. This was the cheapest option. Again, you have to give them options. If you go buy a suit and they only have suits Hugo Boss for $2,000, but you can't afford it, are you going to buy it? No. But if you go and see this is a suit for $200, that's a suit for $300, that's a suit for $750, and this one is for $3,000. I know I can afford the $200, I'll pick the $200. The same thing for the patient. I give them option. I say, look, this option costs $15, this is $25, and that's $45. And she goes, no, I want to go with this one. So again, there's no one size fits all, and I don't charge the same amount of money for my, so I know some of my colleagues, they say, oh, $30,000 for a hybrid, no matter what you choose. I don't do that because I know that not everybody can afford $30,000. So that option is the cheapest option in the fixed. I use locator abutments, so they're cheaper for me than using multi-unit abutments. And then I attach, so the hybrid is fixed, but I can take it out if I have to clean. So you see, so that, again, it's, and then the other thing is in case there is wear, because the opposing is natural teeth. Some of her crowns are made of zirconia. If she has wear, I don't have to worry about how I'm gonna fix it. I just take it out, I have the file, I mill another overlay, take the one that is worn down, put a new one in there, put it back, and let her go. See?
Thank you. The other question is, there was another case with the framework, and you said you add a pink composite.
Yes. Okay.
How predictable is that with a composite on a metal?
Okay. It's a very good question. Now, for this one, the teeth are made of zirconia, but the base is made of composite. Now, don't forget, at the gingiva level, there is no wear, isn't it? Except for the brushing. But there's no wear, there's no occlusal forces. So it's very predictable. In case it wears with the brush, you polish it. In case something happens, you can fix it. Does that make sense? Now, for the zirconia crowns, they're individual crowns. In case they break, I have the lab mill another crown for me, take the old one, place a new one in. It's very predictable. And they're cemented with resin composite cement. So knock them off, put a new one. Okay?
Other questions?
I have to kindly ask you to move forward because I can read your lips. I might not be able to hear you, but I use the microphone. Use the microphone.
Doctor? Doctor, there is any design, you know the gap between the implant, the gap between the implant, the ridge, any design to give a stimulation to the ridge, so by time no bone resorption.
I didn't understand your question.
This denture.
Get closer, closer. Put your mic closer.
This denture, there is implant.
Okay.
Implant. The gap between the two implants, the ridge by time will be resolved because no stimulation, any design to give stimulation to this ridge, so by time no bone resorption.
When you have a denture or a hybrid or any prosthesis that sits on the implants, it creates load, yes. And then it's distributed in the bone. So the bone is stimulated. Yes. You understand that?
This is the gap between the two implants.
It doesn't matter. It doesn't matter. For me, I'm a prosthodontist. I inherit these cases. They are referred to me. Sometimes they're all of them close to each other. Sometimes they're a mile away. Sometimes they're angled. Sometimes they're straight. You have to live with whatever you have. But if you want to think about it that way, it doesn't matter if an implant is here and another one is here. The load is distributed also in the bone. Yes.
Okay. Thank you.
Yeah.
Thank you.
Amazing lecture as always, Dr. Baba. What are the times that you cannot do digital dentures?
Say that again?
When you cannot do digital dentures and you go conventional?
Okay. I love digital dentistry. It's very practical, it's very efficient, it's very accurate. But not everybody is a candidate for digital dentistry. For example, let me go to the basics, which is the easiest. It's complete denture. You see, I'm doing CAD/CAM, mill dentures, and printed dentures. I do digital impressions, but some cases where there's a lot of bone resorption, a lot of saliva, a huge tongue, it's not practical. So you have to use conventional impressions. Same thing with implants. Patient is difficult, with a lot of saliva. You just better probably sometimes to go with conventional impressions. You understand? I do sometimes the combination of both. I make a conventional implant impression, but I go back and I do a digital one so I can have a backup and I can compare. So again, the digital dentistry is excellent, but it's not a solution all the time. So that's why you have to learn to do the conventional way also and have a backup. See? So that's my opinion.
Thank you.
Dr. Baba, thank you for coming. We know everybody here, it took us 20 minutes to attend the place, and it took you 17 hours to reach the country and 17 to go back to the States. Thank you so much, appreciate it.
Thank you.
In the case of hybrid, the metal framework, there is many options, or we use only one kind of, is it titanium, metal, or gold? Thank you.
The milling center that I work with gives you the option to do either titanium or cobalt chromium. So you can do either or. So one of them is cheaper than the other. So cobalt chromium is cheaper than titanium. So the difference is the force, is the strength of the material. Depends what you're doing. If it's a wraparound, I can go with cobalt chromium, it doesn't matter. But if I'm doing zirconia, I go with titanium. But regardless what material you choose, it's very important to do a verification jig. So that's why I like to have a conventional impression. Then once I have the cast that comes from the lab, I take the impression post, put them in the patient's mouth, put the floss, splint them together with the floss or with composite, Duralay, whatever material you want. And then what I do is I take it out and try to seat it on the cast. And if it does fit on the cast, that means my cast is accurate. Because the most accurate cast is the patient's mouth, isn't it? So you want to make sure that whatever you have in the mouth, you have on the cast. If not, it's going to be off. Titanium or cobalt chromium cannot be cut and soldered. In the old days, when I started brass, we used to use yellow gold. If it doesn't work, all what you do is what we do is we used to cut and solder. Now, it doesn't fit, you have to make a new one. And the lab is going to charge you for a new one. If you tell them, hey, it's not fitting, it's not their fault. So they're going to charge you for another one. And it's not cheap because they charge per implant. It's $289 per implant. So if you have 6 implants, that's another bill. It's painful. So that's why it's important to have a verification jig. Some labs do not accept to mill for you the titanium framework or the bar or anything before they see your verification jig. So.
Thank you, Dr. Baba, for the informative lecture and for coming to US.
Thank you very much. I'll hold it with you. Thank you. Thank you, everybody.
We'll have a prayer and lunch break, and we'll continue at 1 p.m.